Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about breast cancer in young women with Dr. Ann Partridge. Dr. Partridge is a professor of medicine at Harvard Medical School. Here's Dr. Weiner.
So we're going to talk about breast cancer tonight. We're going to talk about breast cancer specifically in young women, and we may stray off into some other areas as well, but that's going to be the main topic. But before we get there, Anne, if you could just tell us a little bit about how it is you became a doctor and how you wound up doing oncology and breast cancer.
My mission to become a doctor started when I was literally in, I think, maybe preschool, and then germinated further in elementary school and beyond. I grew up in a family where my father was the primary parent, and he was a surgeon. And he took my siblings and I on rounds with him, not infrequently, when this was still allowed. And we spent a lot of time in the nursing stations and eating all the snacks. But we were also very, very engaged by the work he was doing and the meaning of that work for the people he was caring for and to him. And that was, needless to say, life-altering in many, many ways for me as a young, impressionable kid. And as I became an adult, I realized that I too wanted to follow that pathway into medicine. And
did you occasionally get dragged into rooms with patients standing next to your father?
Oh, yeah, all the time, all the time. And my father was, he not only did you get dragged into rooms with patients, but we could be out in the store. And my father, who was a general surgeon, he's retired now, would find a spot on somebody's neck in the line next to him and say, you really should get that checked out. So it was also real world medicine too. And he was often right. There was something not good going on. So we kind of lived it because he was also, helping to take care of the neighbors and the neighbors' kids and things like that. So we lived it as kids. And, as I moved into the making my own decisions with that impression, what led me to oncology was both the science and the exciting things that were taking off in terms of understanding of why cancers form and how we could better manage and get rid of them for patients, as well as the people who were doing oncology. And finally, the experience with patients over time, helping them to deal with a very, very serious illness at times and to manage that, and the privilege of kind of being a part of their journey and helping to navigate them through that.
Wow. Well, you've certainly had a great career so far, not that it's close to being over, in oncology and specifically in breast cancer. So let's talk about young women with breast cancer. And first, maybe you could tell us, how common a problem is this? If we take women under the age of 45 or 50, how often is breast cancer diagnosed?
So it's not a common problem. We don't want anybody leaving this podcast and thinking that this is somehow an epidemic of breast cancer in young adults. But yet it is the most common cancer diagnosed in people who are between 20 and 45, or, kind of the conventional adolescent young adult age groups, and is certainly the most common in women in terms of young adults. And so it occurs in about, depending on where you put the age cutoff, somewhere between 10 to 16,000 patients a year annually in the U.S. alone. And of course, many thousands more women worldwide.
And would that 10,000 figure be women under the age of 40?
Yeah, 10,000 is about the numbers for under the age of 40. And one of the latest things is that those numbers appear to be going up, not just the absolute number because our population is growing in the United States, but the frequency with which a person is diagnosed, the likelihood of being diagnosed is actually going up in the young adults. So trying to figure that out is really important because we obviously don't want that to happen more.
And that's a change because for years and years, patients would say to us, there seems to be more breast cancer in young women. And we would typically say, no, it's not changing that much. But it's been the past several years that trend has seemed to emerge.
Yeah, that's exactly right. The latest data suggests the prevalence is growing per, the population. But originally, when we first looked into this, as you and I know, and as you alluded to, we've been looking at this for 2.5 decades. When we first started looking into it, it appeared that it was just the absolute numbers and that the population itself was growing, but that the frequency within the population wasn't growing, or the prevalence. But now it does appear that it is growing even within the population, per 100,000 people.
All right. So breast cancer in young women is in some ways the same and in some ways quite different than breast cancer in older women. And maybe we could start off talking about some of the unique challenges that a young woman faces. And let's sort of think about the age cutoff is somewhere in the mid-40s.
Yeah. So, the way I think about it is that many things are the same. And young women, just like old women, care about both how they feel and what they look like and whether they have good sex or not and things like that. But many things are accentuated by being young. And that includes things like, where they are in their lives, their role functioning. A young woman is way more likely to be starting a family, starting a new job, trying to finish education, in a newer relationship and trying to work through those kinds of things compared to an older woman. She's also more likely to have, a little less resilience. She hasn't seen, this go on in her friends before, most likely. She probably cares a little bit more than some older women about their, her physical health, in terms of her sexual health and her body image. Not that older women don't care. And so it's really just a kind of, a highlighting it more, feeling it more as a younger woman on average, not all women, of course. And then there are things that are unique to being young, or way more common when you're young, like, fertility. A young person, if you cut it off at 40, your average 45-year-old, if they're going to have kids, is done with having kids. Whereas your average 30, 35-year-old, probably not.
The importance there is that if someone gets chemotherapy, they're at risk to potentially lose that fertility.
Exactly. The treatments can impact fertility directly. And then the majority of young women will have hormone-sensitive breast cancer that expresses estrogen or progesterone receptor. And as you know, we use that to treat them, and we use anti-estrogens or lower their estrogen to try and treat them to help make their breast cancer not come back or keep it under control. And during that time, you should not get pregnant, because those treatments can cause birth defects, or you can't become pregnant because your ovaries are suppressed. And so there's a time issue there where the ovaries are aging. And that's a hard one for our young patients who haven't completed their families or even started them.
And oftentimes those hormonal treatments are particularly difficult for younger women.
Very much so. Again, not to say that these treatments are a cakewalk for our older women, but for our younger women who, they're not starting to have hot flashes. They, are often kind of not even close to menopause by their age and or their physiology. And then when we give them things that lower their estrogen or block it completely, they can become very, very symptomatic. And often also are not as equipped, because again, their friends aren't dealing with this. Their friends instead are having babies or going to a club or, finishing school. They don't have all the help to support them on managing of the various symptoms that are typical for women who are in like middle age.
And there's some popular folklore out there that somehow breast cancer in young women is much worse, and that young women are far more likely to lose their lives from breast cancer than older women. Can you comment on that, and to what extent that is true or not true, or just tell us a little bit more?
So from a disease standpoint and a psychosocial standpoint, an emotional standpoint, if you look at a big picture, that folklore is actually true. On average, if you're diagnosed with breast cancer, you are less likely than an older woman to make it through and not die of breast cancer, meaning you're more likely to die of breast cancer on average. And you are also more likely to suffer emotionally in follow-up, including long-term follow-up. That's part of the reason I started focusing on this, because I said, how can we fix that disparity? Young women are a more disparate group from a medical and an emotional standpoint. But that's the big picture. The important message inside that big picture is most young women will be long-term survivors and will not only survive, but hopefully thrive through their breast cancer. And that's getting better and better with our medical advancements. And then young women don't develop just one breast cancer, just like older women don't develop like some, monolith of the same exact breast cancer. There's a spectrum. And young women are more likely to be diagnosed with more aggressive breast cancer, but they can also be diagnosed with not so aggressive breast cancers, and that don't warrant, major aggressive therapies, as in, chemotherapy or, mega treatments. And so just like with older women, but perhaps even more so with younger women, where everybody's worried and wants to, make sure they get rid of the cancer, they have to be careful that they tailor the treatment. We have to be careful to tailor the treatment to the disease in the context of the human being who's, unfortunately been diagnosed with it. So it's a nuanced answer that is yes, on average, but the message is most women will be okay. And we have to be careful not to overtreat our young women because we're worried about them.
And that, yes, on average applies mostly to women under the age of 40, maybe less so in women who are in their fifth decade or between 40 and 49.
Yes, and absolutely. Young age is a moving target for me right now, as you know. And so, yes. So when I'm thinking about the age disparity, it really is the under 40 and particularly the under 35 on average when we've looked at this on a population basis. Actually, women in their 40s, which is still young, but not our conventional very young, women in their 40s actually do the best in terms of their overall survival. They do have issues, and it depends on where they are in their lives with regard to the emotional things. And of course, some of them still want to have babies and are, younger in terms of their goals in life. And so that's why we think about them when we think about supporting them more, and tend to target women into their mid 40s to allow them to define their own young. How about that?
Yeah, well, and this idea of age being a moving target, at the risk of teasing you a bit, I do remember when the program that you started at Dana Farber focused on breast cancer in young women, when initially the age cutoff was 42, and as you advanced in age, that cutoff went up a few years.
That went up for other reasons, but it was coincident with my aging out of it. And, I was happy to fortunately have become a member. But that being said, it very much age is a state of mind. But that being said, I think we target and think about women who are in their 30s and early 40s for the structure and the programmatic approaches. But when we think about where the disparate outcomes are, it really, from a disease standpoint, it is the younger women, the very young women. The one thing I wanted to add is there's also the genetic component. And, we talked a little bit about the disease itself, but one of the things that's kind of a hallmark of young onset breast cancer is there's a much higher likelihood of having a genetic predisposition to the disease when you're diagnosed as a young woman. If you include some of the newer genetic changes that you can find in genes that we now know increase risk of breast cancer, if you look at women under 40 and certainly under 35, it's almost a 25% chance of finding, if they're diagnosed with breast cancer that young, there's about a 1 in 4 chance of finding one of these hereditary predisposition. And that's in contrast to older women where that's more like, a 10% chance, which has both ramifications for their treatment, both what they choose to do from their breast cancer, the breast surgeries and treatment locally, as well as now what kinds of treatments systemically, the medicines they can take to treat their cancer. And it also obviously has implications for their loved ones and their blood relatives who may also be at risk by virtue of having a genetic predisposition and can cause, it's knowledge is power, but that can also make people quite distressed because, of course, you don't want yourself to have cancer, but God knows you don't want your children or your loved ones to be also diagnosed potentially with a cancer. So it adds to I think, the psychosocial distress these patients face.
Well, we're going to take just a very brief break. And when we come back, we'll pick up with some questions about genetics and breast cancer. So we'll be back in just a minute.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their hematology program offers comprehensive diagnosis and treatment of blood cancers, including lymphoma, leukemia, and myeloma. SmilowCancerHospital.org. Over 230,000 Americans will be diagnosed with lung cancer this year, and in Connecticut alone, there will be over 2,700 new cases. More than 85% of lung cancer diagnoses are related to smoking, and quitting even after decades of use can significantly reduce your risk of developing lung cancer. Each day, patients with lung cancer are surviving thanks to increased access to advanced therapies and specialized care. New treatment options and surgical techniques are giving lung cancer survivors more hope than they have ever had before. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as the Battle II trial at Yale Cancer Center and Smilow Cancer Hospital, to learn if a drug or combination of drugs based on personal biomarkers can help to control non-small cell lung cancer. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Eric Weiner with Yale Cancer Answers, and I'm joined by our guest, Dr. Ann Partridge, professor of medicine at Harvard Medical School, and a breast cancer physician and interim chair of medical oncology at Dana Farber Cancer Institute. So we were just talking about genetics in breast cancer and the more frequent finding of a gene change or gene mutation that is inherited from one's mother or father that increases the risk of breast cancer. How does having such a change, such a mutation, like a BRCA1 or BRCA2 mutation, which many people are familiar with, how does that affect decision-making regarding treatment?
Having a gene mutation or pathogenic variant, as we call them these days, can have a major impact on especially what a young woman considers in terms of her local therapy. Local therapy meaning surgery with or without radiation. Generally, a person needs to treat the breast where they have the cancer from a local standpoint in order to get rid of it, along with often medicines or systemic therapy to kill off cells that might have been left behind. When a young woman or any woman has one of these known hereditary predisposing genes or a pathogenic variant, her risk of having a new primary cancer in the breast tissue goes up pretty dramatically, often something on the order of 5 to 10-fold, depending on the level of the type of gene they have. And so, our job as medical oncologists working with our genetic counselors and geneticists is to, if a person tests positive for one of these genes, the changes in the genes, then we need to help decide, is it one of those ones that is associated with a really increased risk of new primary breast cancer, either in the same breast where they had the original breast cancer or in the other breast or contralateral breast, as we call it. And then should that, for that individual woman, impact on her decisions around doing more aggressive surgery? Often women will consider not only treating the breast where they have the cancer, but the other side in terms of having a prophylactic mastectomy, so that they can decrease the chances of a future breast cancer event in that breast. And of course, that has a lot to do with, well, what are the risks of the first cancer? Number one, hopefully if the risks are low, that woman will be expected to, live and live on for many years, in which case the idea of a new cancer occurring in the next 5 to 10 years would be super important, let alone 20, 30, 40 years from then, if you're talking about a 40-year-old. And so we often help, discuss these issues with women. It's complicated because some of these women haven't finished their childbearing. They might want to not only just have a baby, but nurse that baby. So some of these women will say, okay, I have a known hereditary predisposition. I'm just going to treat the side I have to now, but I'll think about doing something on the other side when I'm done with having my children. But, some of them are living with increased risk even in the first 5 to 10 years. And most of them, if they have a known predisposition. And so that's kind of a weighing pros and cons there. And it's important that we support them to make the best decisions for themselves. The good news is that at least in the short term, women aren't usually sitting on a time bomb. They feel like they are, but generally you have some time both to make these decisions when you're treating the primary breast cancer, as well as to hold back and not necessarily do many prophylactic things right at the beginning. You usually have at least a couple of years and can be watched very carefully, even with the highest risk genes.
And of course, for women with BRCA1 or BRCA2 mutations, there's the added risk of ovarian cancer, which, of course, with many of these gene changes, people are at risk for a variety of different cancers, but ovarian cancer is the one that is most notable for some people. And that also sometimes leads to questions about prophylactic surgery. So we've been talking off and on about having children after breast cancer, having babies, and fertility. And maybe you could tell us a little bit about the study that you conducted looking at pregnancy after breast cancer, because for years and years and years, women have asked us, is it safe to become pregnant after breast cancer? And the usual answer was, we don't know that it isn't safe. It's probably okay, but we don't know the exact timing. And then you and your colleagues were able to do a really landmark study.
So we heard from our patients and our patient advocates how, we knew how important this was for our young women and their families to be able to have babies and also at the same time not do something crazy, right? It's pretty normal to want a baby, and yet people want to get good breast cancer care too and good risk reduction. And so what we did was a single arm trial where we said, okay, let's come up with a protocol that seems reasonable to your average patient advocate, and doctor who cares for young women with breast cancer.
And just to be clear, you say a single-arm trial. I think people know that oftentimes there are randomized trials, which are definitive trials, but it is hard to randomize people to getting pregnant or not.
Yes, that would be a very challenging study to do, a non-starter. And so we said, what would women tolerate? And we actually figured out a schema, again, with very heavy patient input, that women were willing to take their endocrine therapy, but really wanted to take a break if we didn't think that was crazy, and then get back on. They were willing to get back on. So the idea is typically you treat for 5 to 10 years, straight through with oral endocrine therapy and sometimes with shots to suppress ovaries. But we know that the risk of breast cancer continues for the hormone sensitive breast cancer even further out. So could we take a break sooner than that 5 to 10 years? Allow women to support them. We don't allow them, support them to get pregnant, however they needed to get pregnant, and then get back on and complete the full duration of the therapy they were going to take. And the really good news is that women all over the world, this was a very big international effort. We put on over 500 women around the world. I think it was 80 countries we enrolled from, and we actually enrolled in record time. And what we showed, at least in early follow-up, is that this does appear to be a safe approach. So taking 18 to 30 months of your treatment, taking a break for up to 2 years for a pregnancy, delivery, nursing if someone chose to and is able to, and then getting back on the therapy. When we followed these women over time, they seem to do just as well with as few recurrences as women who had not taken that kind of break for pregnancy.
Well, I think it's admittedly a preliminary result, but it's really a much more definitive study than has ever been done, and has really helped in decision making around this really challenging issue for a lot of people. Could we talk for a minute about long-term complications? So a woman goes through treatment for breast cancer, and a young woman may live for another 50 plus years. What are the long-term implications of a diagnosis?
So we know from anecdote, actually, the long-term implications, and from uh, some studies where we have looked at kind of populations overall, but we don't have a great amount of data on very young women diagnosed with breast cancer, what's happening to them 20 years out or 30 years out. And in fact, I'm excited that the study that you and I launched now 20 years ago will actually deliver some of that data in the years to come, because we've been following a cohort of young patients, and we'll continue to follow them hopefully for another 20, 30 years. But for now, we worry about their bones, we worry about their hearts, we worry about their mental health and even their cognitive functioning over time. And that's largely from studies that have looked at not breast cancer survivors, but women generally who've gone through very premature menopause for different reasons, and have shown in these studies that there may be an increased risk of some of these chronic diseases, particularly bone health and the risk of premature cardiovascular issues. That doesn't mean we shouldn't use these treatments, because the near risk for women is breast cancer, right? We want them to become long-term survivors, and we have to, but it does mean we shouldn't overtreat them, number one. And number two, we want to follow them long-term and do whatever we can to prevent these long-term and late effects as we figure out how frequently they occur and what we can do to prevent it.
Well, in our last 2 minutes, maybe we can touch on a really important topic, which is screening. And of course, screening recommendations typically start in women who are 40 or over. For women who have a genetic predisposition to breast cancer, we often do start younger. But for the general population, women who do not have any kind of strong family history or genetic predisposition, there's a lot of discussion about what can be done with screening in young women. And what are the challenges there, and where do you see all that going?
Yes, that's a very complicated situation. Right now, for general population, there is no good screening for young women who are at risk for breast cancer. And basically any young woman, if she has breasts, is at risk for breast cancer. Yes, for the high risk population, if they know they have a gene in their family that predisposes to breast cancer, we'll start getting MRIs and mammograms earlier, and that's tailored to the individual and their family history. But for general population women, there actually is not a great test. So it's really about your own breast health awareness. And that's not a great answer, because many young women, by the time they feel a lump, they're diagnosed and they have higher risk disease than they would like. And so what we really need to do is to do more work to figure out who's really at risk for breast cancer, to really understand not just what are the smoking gun, one gene that predisposes, but more things like polygenic risk scores, where we can understand the genes and the environment interaction. And until then, and we need better tests also. So we need tests that are better than a mammogram, because mammograms aren't terrific in young women who have much more dense breasts than older women conventionally, and therefore seeing a dense tumor different from a dense breast is much harder in a young woman with a mammogram.
Dr. Ann Partridge is a professor of medicine at Harvard Medical School. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.